Hello, sir. Good evening. This is from India. Thanks for joining.
You're welcome.
Good afternoon, Dr. Noveltis. This is Altaf Kazi. Good afternoon to you.
Hi, good afternoon. Sorry I'm a bit late. I've just been on other calls and it's been very busy, and I had a busy clinic this morning that went over. So, yeah.
No worries.
You're all familiar with it, you know.
One minute to start. 1 minute to start, please.
So listen, will I share slides here or will you share them from there?
Yeah, no, you'll have to share the slides, sir, because I don't have your final slides with me.
Well, I didn't change anything. I think I can share it from here, no problem. Yeah.
Yeah, okay, fine. In case you're not able to, then if you're not changed anything, we'll share it from here.
No, I can share it from here. So I think, and then we can have a discussion as we go along. It'd be great.
Right. All right.
Do you want me to share just now? I could do it now.
No, not yet. So there will be a welcome address, and then hand it over to the chairperson, and then you can start after they talk.
Okay, no problem.
Thank you. Start in 10 seconds, please, Mr. Kazi.
Yeah, Mr. Patni will take over. Yeah.
Yeah, 5, 4, 3, 2, 1. Please start.
Recording in progress.
Good evening, doctors. I am Pradeep Patni. I look after Acumentis. Great pleasure to have you here with us today evening, and I hope you and your family are healthy and safe. Before we start, I thought I'll give you a quick sense about Acumentis. Doctors, Acums is India's largest manufacturing setup, and 12% of all the pharmaceutical tabs, caps, injections, etc., which are sold in India come from our stable. Acumentis is the formulation marketing setup under Acums, and we currently span the therapeutic areas of gynecology, pediatrics, ortho, dermatology, ENT, and of course, cardiology and diabetology. Quite a few brands of ours, maybe not in this therapeutic area, but in others, were first of their kind, and we take great pride in successfully launching innovative formulations. Going forward, we would want to create initiatives that will make us more relevant and visible in your clinical practice. And we look forward to your advice and suggestions that will help us make our products benefit more and more patients. Thank you so much, Doctor. I'm sure it would be a wonderful evening. And over to you, Altaf.
Thank you, sir. At the outset, I, Altaf Kazi, take utmost privilege in welcoming all of you to this prestigious and important EASD Konnect initiative. I'm proud to say that here that the objective of Acumentis and our division, Noveltis, is to promote the notions of continuous learning among diabetologists and endocrinologists. I also take utmost pride and privilege to welcome all esteemed faculty and delegates to this important EASD Konnect initiative. I'm indeed thankful to Dr. Bipin Sethi, Dr. Prasanna Kumar, Dr. Uday Phadke, and Dr. Sanjay Kalra for participating in this initiative. This special wrap-up session is a culmination of those daily updates, and to do so, let me welcome Dr. Prasanna Kumar from Bangalore, who has graciously agreed to be the moderator of this EASD Konnect initiative. I will just take a minute to share the slide, if I can share the slide quickly for the introduction.
Yeah, please go ahead. Please go ahead.
Yeah. So, Dr. Prasanna Kumar, welcome once again. Dr. K. M. Prasanna Kumar has been practicing since 1980 and has vast experience in his field. He is currently attached to the Center of Diabetes for Endocrine Care. He is also CEO of Bangalore Diabetes Hospital in Vasant Nagar. In addition, Dr. Prasanna Kumar has been teaching undergraduate, postgraduate, and postdoctoral students at MS Ramaiah Medical College in Bangalore. He has been president for Endocrine Society of India, has been president for Research Society for the Study of Diabetes in India, has been vice president for Diabetes India. He has extensive research involved in clinical and academic research in 1992 in the fields of diabetes and endocrinology. He has more than 100 articles pertaining to endocrinology, diabetes, and metabolism published in national and international journals. He has immensely contributed to chapters to RSSDI textbooks of diabetes, Endocrine Society of India, Manual of Endocrinology, etc. So, Doctor, welcome to this important event. Let me also welcome Dr. Uday Phadke, who has been at Sahyadri Hospital, Hormones and Diabetes Care from Pune. He's a well-known endocrinologist and diabetologist from Pune. He has received multiple awards during his academic years. Dr. Phadke has completed MBBS from BJ Medical College, which is known to produce top-class medical professionals. Has been awarded with Srimati Bhandarkar Memorial Award for excellence, academic excellence in the DM examination, and a special citation by the University of Bombay. for securing highest marks amongst all candidates. After passing the DM examination, Dr. Fatke worked as a lecturer in endocrinology at KM Hospital for about 6 months before return to start his own practice. Dr. Fatke also holds an advanced endocrinology preceptorship from the prestigious Johns Hopkins Institute, Baltimore, USA. In 2015, Dr. Fatke was awarded the prestigious fellowship of the American College of Endocrinology. Dr. Fatke has wide experience in treating patients with diabetes and endocrinology disorders. Dr. Fatke, welcome.
Thank you.
Dr. Sanjay Kalra has been Vice President of South Asian Federation of Endocrinology Society. He has been attached to endocrinology as an endocrinologist with Bharti Hospital, Karnal. Has been a sound scientific foundation. Dr. Kalra has been instrumental in providing editorial skills to several national and international medical journals focused on various variety of subjects like endocrinology, diabetes, geriatric, family practice, medical research, pharmacology, hypertension, and nutrition. He has an executive director of the Indian Journal of Endocrinology and Metabolism and editor-in-chief of the International Journal of Clinical Case and Investigation. He enjoys various prominent positions in medical societies, one of them being the rank of the Vice President of South Asian Federation of Endocrinology Society, which I just mentioned, since 2013. He is an international lecturer and author of numerous published peer-reviewed research papers and active peer reviewer. He has delivered a cornucopia of lectures on various aspects of endocrinology all across Europe, America, Africa, and Asia. With over 200 papers published till date, Dr. Kalra is associated with significant contribution in publication. He has a plethora of experience as a clinical research investigator in the areas of diabetes, hypertension, osteoporosis, dyslipidemia, obesity, contraception, and male infertility. His outstanding research background has earned him several national clinical awards, including the Investigator of the Year 2008 from the Indian Society of Clinical Research, the Dawn Award in 2009, and the Professor B.N. Srivastava and late Mrs. Sundar Lari Srivastava Award 2012 from RSSDI. Welcome, Dr. Sanjay Kalra. Good afternoon, Dr. Naveed Sattar. Dr. Naveed Sattar is a professor of metabolic medicine, Institute of Cardiovascular and Medical Sciences, University of Glasgow, UK. Dr. Sattar is a top healthcare professional specializing in endocrinology, diabetes, and metabolism and cardiovascular disease. He is renowned for his work in diabetes. According to the University of Glasgow, where he works, he is known for his epidemiology work in diabetes, working primarily with Scottish, Swedish, English colleagues, but also others around the world. He has been a key participant in relevant emerging risk factor collaborative papers, as well as leading other local papers within his own group. Dr. Sattar is an honorary consultant in metabolic medicine at the Glasgow Royal Infirmary. He is currently leading 5 clinical trials regarding heart failure, insulin, diabetes, and one regarding the coronavirus effect on the heart and lung. At present, Dr. Sattar has co-authored a total of whopping 1,469 publications throughout the span of his career. These publications have been cited 94,300 times. He has led and participated in 36 total clinical trials. The top conditions for the trials have been diabetes as well as type 2 diabetes. The top intervention have been candesartan and placebo. So Dr. Naveed Sattar, thank you for joining us. Welcome to you. Now, may I request Dr. Prasanna Kumar to take the proceeding forward from here.
Thank you, Altaf Qazi, for the nice introduction and generous introduction as well. Welcome to all the delegates for today's highlights of the EASD or Pulse of EASD. As you know, EASD was held from 28th September to 1st October. And in 3 days, nearly 700 oral presentations were done. There were 8 halls. And to go through all these halls, whether virtually or physically impossible, and maybe very impossible also to go through all this. That's why we have guest faculty, Dr. Naveed Sattar, who is going to bring us the pearls of the highlights, what he thinks is the best of the articles for clinicians as well as the academic persons, and his opinion about these articles. What do we gain from that? What is the knowledge that we get? How do we translate that knowledge to our practice? To tell us all about this, we have Dr. Naveed Sattar. At the end of his talk, we have got 2 chairpersons along with me, Dr. Sanjay Kalra and Dr. Uday Padke, and we will discuss those papers. We'll ask questions to him. I request all the delegates that if you have any questions, please put it in the chat box, put your name and the city from which you are asking this question, so that we'll be answering this question with your name. Over to Dr. Naveed Sattar for his talk about Pulse of Highlights of EASD 2021.
Thank you. Hope you can see. Can you see those slides? I hope you can.
Yes.
I don't know how to make it full view but anyway, I think you can see it probably pretty well. There you go.
Yeah, that's okay.
So let's start with this first one. I think it's from, wait a second, the efficacy and safety of dapagliflozin on kidney and cardiovascular outcomes by baseline albuminuria. So this is a secondary analysis from the DAPA-CKD trial, which one of my colleagues, John McMurray, was involved in, but led by Guido Hirschbank, who's a brilliant young nephrologist from let me see. So this is a pre-specified, secondary analysis. What they looked at was the effects of dapagliflozin versus placebo based on urinary albumin creatinine ratio at baseline less than 1,000 mg per mg, between 1 to 3,000, 3,500, or greater than 3,000. Excuse me 1 second. And the primary composite outcomes were sustained greater than 50% declining EGFR or end-stage renal disease or death from kidney or cardiovascular disease. And then they also had a number of secondary outcomes. So this is the top line data. So in terms of primary outcome, regardless of whatever the baseline albuminuria was, the relative hazard benefit was exactly the same, almost identical, no interaction whatsoever. But notice those people who had higher albumin creatinine ratios had higher absolute event rates, particularly in the placebo group, 3.7 up to, so almost a tenfold difference in event rates based on albuminuria. So that means the absolute risk reduction was greater. Even if the relative is the same, the absolute risk reduction was greater in those who had higher albuminuria. And that's because a 40% reduction based on a baseline of 31% gives you a 13.8% absolute risk reduction, whereas a 44% based on 3.7, it gives you much less absolute benefit. So that's what you basically see. But nevertheless, the relative benefit is exactly the same. The absolute benefits are dependent on albuminuria. And this is the same, looking at the relative benefits in people with diabetes is pretty much the same, no interaction, P093. And again, in people without diabetes, the benefits were broadly similar. I mean, there's some wobbling, but the numbers are small, no interaction. Again, as you get more albuminuria in people without or with diabetes, at the bottom, you see the absolute event rates in the placebo group are the greatest, 28%. And 46%, so again, for the absolute benefits and the numbers needed to treat will be smaller in people with more albuminuria. And in terms of EGFR decline, I'm not going to show you the acute slope, but you all know this. Acutely, EGFR declines with dapagliflozin, but then it recovers. That it recovers. But what really matters is the chronic slope. So if you start with low albuminuria, medium, moderate, or high, you can see that the EGFR decline was greater in the placebo group in each case, and it was reduced with the dapagliflozin in each case by around about between 1 to 2.5 units in EGFR slope units per year. So that's really the chronic slope, and that's the totality of chronic plus acute. So these drugs benefit people regardless of albuminuria in terms of relative terms is the summary. Let me see, have they got a summary? Let me just see, actually. Oh, they don't have a summary. Yeah, oh, they do. Dapagliflozin consistently reduced the risk of kidney and cardiovascular outcomes across the subgroup of baseline albuminuria. The consistent in patients with and without diabetes, effects of DAPA and EGFR were consistent across subgroups defined by urinary albumin creatinine ratio. The proportion of adverse events leading to, I didn't mention this, to study drug discontinuation or serious adverse events was similar across urinary albumin creatinine subgroups. Taken together, these findings support initiation of DAPA in a broad group of patients with stage 2 to 4 CKD, regardless of baseline albuminuria or the presence of type 2 diabetes. So I'm happy to stop there if you want any questions there specifically. I don't know if there are any, or I'm happy to continue. Do you want me just to carry on, or?
Yeah, it can complete, Dr. Naveed. Then at the end of it, our chairpersons as well as the audience.
All right, okay, let me complete. So just tell me when to stop. There's a lot of material here, but I think the first one was relatively easy and straightforward. Now, this is a very simple study. It's a Sustain 10 as a kind of phase 3 trial of semaglutide and liraglutide. And they basically looked at the efficacy, at least in terms of risk factors, but not in outcomes, of these two, semaglutide and liraglutide, on the background of baseline SGLT2, and it's a post-hoc analysis. And what they found was, unsurprising to you, semaglutide and liraglutide reduced hemoglobin A1C from baseline regardless of SGLT2 use. So if you look at the semaglutide, I hope you can see my arrow. If you add semaglutide 1 milligram without baseline SGLT2, you get about 1.8% reduction in hemoglobin A1C. On the background of people on SGLT2, you get a 1.6% reduction. And that might be because people who are on baseline SGLT2 have got a lower baseline hemoglobin A1, because if the hemoglobin A1 is slightly better, you will get less reduction. And you see the same in liraglutide, 1.2 milligrams without SGLT2, 1.1% with 0.7. Now, the really interesting thing is how much more semaglutide gives you compared to liraglutide. You get an extra almost 0.7%, between 1 to 0.7 to 1% lower reduction in hemoglobin A1 with semaglutide compared to liraglutide. And that's probably because I think this is probably a better GLP-1, but I think it's also, you get much more weight loss, and weight loss effectively improves the pathophysiology of diabetes right at the top upstream compared to any other drug that you know. In terms of body weight, actually, here you go. Here's the evidence. I forgot that this data were in. If you look at body weight difference, 1 milligram semaglutide, you're losing about 5 or 6 kilograms compared to 1 to 2 kilograms of liraglutide. And that extra 4 or 5 kilograms is giving you reduction in liver fat. I would imagine it's giving you an improvement in reduction in insulin sensitivity, and therefore more likely to give you a bigger hemoglobin A1C benefit, which is what you see. So what did they conclude? Addition of GLP-1, semaglutide or liraglutide to an SGLT2 was associated with further reductions from baseline in hemoglobin A1C, body weight, and systolic blood pressure. I haven't shown you that, but that's true, without additional safety concerns. They're in line with the other studies and analysis investigating the addition of GLP-1, including a post-analysis of Pioneer 4. And these data expand the evidence base of the safety and efficacy of combining GLP-1 and SGLT2 and are valuable to clinical decision-making. That was their conclusion. Now, of course, the best data in terms of outcomes comes from the Amplitude O trial, which I was involved in, which we just published. We published at the ADA a couple of months ago. And then there was around about 15% of people in that trial of epiglenitide who were on baseline SGLT2, and the benefits of epiglenitide on MACE and renal outcomes were broadly similar whether or not the patients were on SGLT2. So not only are the risk factors improved on top of SGLT2, but there is emerging evidence the outcomes are also improved when you add a GLP-1 on top on the background of SGLT2. So the next slide, Dominic Pester from Germany, Physical Activity Guidelines East, Meets West. I don't know, this was a symposium, which obviously you're looking at this. And effectively, he says, how does sitting increase cardiovascular risk? So he had this review in Nature Reviews, and I'm not sure I completely can agree with this. I don't think sitting increases cardiovascular risk. I think what he probably means is if you sit more and are less physically active, then yes, you get these things. But I don't think this is an effect of sitting per se, because I spend a lot of time sitting, and I think my blood pressure is excellent. My cardiovascular risk is good because I also break up my sitting by being physically active. But I'm walking about 10,000 steps a day. So I'm not sure sitting per se is bad for you. But people who sit more do have higher risk. It's not because of sitting, it's because you're being less physically active throughout the day. And I think that is the absolute key. So I would take debate with this, and I've had some debates. He went on to look at the dose relationship between physical activity and health outcomes, and he based it on studies that came from our group, based both in women and in men, which we published in these journals. So this is Carlos's paper. And looking at metabolic equivalence, but effectively, if you take 150 minutes physical activity per week in whites, when you look at overall cardiometabolic risk factor control, to get to the same level of risk factor control in Asians, you have to have in men 266 minutes of activity. And why? And I think it's on the next slide. Asians, if you just look at activity alone, Asians obviously have got higher metabolic risk for the same weight, and therefore probably do need to be more active. I wouldn't take this completely with a pinch of salt, because most Asians don't even reach 150 minutes. So they're never going to reach 266. This is in men, and in women it was 232. But it's another way to say that Asians do have to do more to stay fit and active, whether you keep your weight down or whether you become more active. That's my bottom line. So the beneficial effects, basically he showed the beneficial effects of physical activity and the detrimental effects of physical inactivity are well established. And that's true. And I think we've underestimated the importance of being physically active. And one of the messages that I think you need to say to your patients is find some form of activity that you need to do in the context of your lifestyle. So whether it's commuting to work, or find activities that you enjoy. And as a community, what we need to do in India and Pakistan and other parts is get young people to enjoy physical activity and become good at some sports that they will carry on lifelong, whether it's soccer or cricket or hockey or running or whatever. I know there are cultural, aspects that, we need to take into consideration, but physical activity is important. And the only way I keep up my physical activity is I monitor my steps every day on this thing. And if it's low, so at the moment I've only done 3,000 steps, actually less, just 3,000. So I'm going to go for a decent walk after my main meal today of at least half an hour to build up another 3,000 steps, because I know I have to because of my family history of diabetes. So those are the things that I would say to you in your clinical practice. This is a very quick study. I'm not even going to talk to it in detail because it's more in animal models, and I'm not really a big fan of animal models. It's just all it was saying is there any evidence of neuroprotective properties of different diabetes drugs? And they looked at the liraglutide, empagliflozin, and the metformin, and what they basically showed was that yes, compared to placebo, there is some evidence that lira and empa, maybe metformin to a lesser extent, do have effects that when you damage, stress the brain, you might reduce brain volume damage, and you might improve neurological assessment, particularly for liraglutide. And as you all know, there are ongoing trials looking at an SGLP1 receptor agonist. I think it's semaglutide in Alzheimer's disease. And that's all I would say there. And I think we really need to wait for those trials in humans before I would fully believe whether GLP-1 receptor agonists or any other drugs, you need hard outcome trials whether they do have benefits on reducing the risk of dementia or cognitive decline. Okay, the next one is a study that came from Dr. Wernicke from Berlin, as you can see. And they did a randomized trial looking at the effects of a diet high in unsaturated fat and dietary protein, and their outcome was intrahepatic lipids, i.e. liver fat. And they also looked at this biomarker called FGF21. I'm less interested in that, but this is the trial, big numbers. They took 502 people, they randomized half to an intervention, NutraAct pattern. So quite a lot of fat, but most of it was monounsaturated, polyunsaturated. Same amount of protein as the control arm. Same amount, maybe more fat, and they also had quite high fiber intake, 30 grams of fiber. They used rapeseed oil and specifically designed NutraAct foods, and the usual care versus the kind of intervention. So more protein, more unsaturated fat, and more fiber compared to the usual care of 30% fat, 55% carbohydrates, and 15% protein. What did they find? On the biomarker, very little difference and change, but what they did find was a suggestion that in the intervention group that you reduce liver fat levels. You can see in the intervention arm, they had more protein, they had more monounsaturated, more polyunsaturates, and a suggestion that reduced liver fat. What I don't know what the data was, whether the people who got intervention, now they don't have everybody for some reason. I don't know if everyone didn't complete, so you've got to look at the data intention to treat. But what they also showed was people who were adherent to the intervention arm. Now this is post hoc, it's not really it's not an intention to treat, but nevertheless, people who are adherent had a big reduction in intrahepatic fat, liver fat levels, of the order of 40% reduction in liver fat who were adherent compared to very little, maybe a 15% change in the control arm. And then they looked at the biomarker. There's some correlation with the biomarker. But the bottom line I would say to you is that they're eating a better quality diet. I think the evidence on metabolic changes, is the dominant effect of any diet is actually through weight change. However you lose weight, you will lose liver fat. In fact, I had a patient in my clinic this morning who was a colleague of mine. He was who had diabetes 2 years ago, had now got diabetes remission, and he undertook a low carb diet. He managed to lose weight that way, and his liver fat reduced substantially, and his diabetes went under remission. Now he's still struggling to keep on sustaining that, but the dominant effect is weight loss. So if you cut calories, you will lose liver fat, and you will improve your diabetes. In terms of compositionally, I think one of the best ways, and the evidence is increasingly telling us that, is if you eat more fiber, that will certainly help. Yes, there's a link between protein and satiety. That will help, but whether you can sustain that, and clearly that's an issue in poorer parts of Asia, whether they can have a high protein intake, because of the cost of meats and also the climate aspects. But for me, carbohydrate, I'm not sure about the carbohydrate, but I am convinced that higher fiber and better quality of fat, so that in the same way in the trial they tried fats that were long chain. My colleague who was in the clinic, he used to be eating lots of saturated fat, but he's now converted to eating lots of olive oil plus nuts as his main sources of fat. And I think that is better if people are going to want to follow a low carb diet, is to have unsaturated sources of fat and try and eat more fiber rich foods as well. And you get your fiber through your nuts and various other things as well. So that would be my thoughts on that. What we're doing for time? We're doing okay, half an hour. So these are people I know from various colleagues in the past. Max was fun. I think Max used to work for Boehringer. Odd Eric. I think maybe this is a Boehringer solution. And Ian Neeland is a colleague from the US who's done nutritional studies. So basically, this is they've got a whey protein microgel. So they've now made a kind of a nutritional substance in a microgel, and they gave it in a randomized trial in people with diabetes to see, does it improve postprandial glucose? And I'm not going to go through what the formulation. This is what they found was, so can whey protein formulation that do not contribute significantly to daily caloric intake maintain efficacy? Can it, if you take this whey protein closer to a meal, can it reduce postprandial glucose? So this is what they did. I actually don't quite know the detail. Here you go, -30, -15. Yeah, they probably, they gave you this intervention, and then they had they gave you the whey proteins, I think, and then they had meal, and then they looked at changes. Now this is without the whey protein. Here's the glucose goes up and it comes down, and look at the GLP-1 goes up because you have a meal effect on incretin. But then when they added the whey protein, what's really interesting, that the -30, I think the shot means the whey protein. Look, the GLP-1 went up even more, substantially more, by 66%. So it's almost like the whey protein microgel is like a natural way to give you a GLP-1 boost. And as a result, look, the fasting glucose or the postprandial glucose didn't go up as high. Shortly, it did, so that they had a 22% reduction in area, or 18 to 22% reduction in area under the curve for hypoglycemia, and it's probably a GLP-1 effect of the whey protein. And that kind of makes sense because protein can suppress satiety, so it fits with the previous talk. And they also found that, interestingly, having the whey protein gel before your meal, you also increase your first phase insulin. So again, I think that's probably a GLP-1 incretin effect compared to the placebo group, as it were. So compared to placebo, this 125 mils, so 125 mils, it's like a small drink of 10 grams of whey protein taken 15 minutes ahead of a meal significantly increased early insulin secretion by 61% at 1 hour and in 30% at 3 hours, and while altered, and you can see I've shown you the benefits. The reduction observed in early glycemic burden and augmented insulin and sustained GLP-1 supports this convenient pre-meal shot to improve postprandial metabolic glucose. But it's an early trial. They need longer-term studies to see the full translational metabolic impact. And to me, the real metabolic impact would be, how well does it compare to on long-term glycemic control on hemoglobin A1C? Is the key. And also, does it have benefits on weight, and does it have benefits on blood glucose? And how close does it get to the effect of a drug would be my real, of a GLP-1 receptor agonist. But it's kind of exciting. I think I'm only going to present 2 more studies because I want to, I think plenty of time for questions. Of course, lots of new drugs, lots of new ways to increase GLP-1. This is a paper that came out of my colleagues in Dundee. Ewan Pearson is he's a very good colleague in Dundee. Now, Ruth, one of his fellows, she did a study where she looked at low-dose sulfonylurea and combined it to DPP-4 inhibitor, and they wanted to see, does the combination of these two things at low dose, can you get good glucose control as much as a normal dose sulfonylurea, and what happens to insulin sensitivity and hypoglycemic effects? So, hypothesis that low-dose sulfonylurea acts synergistically with endogenous incretins to augment insulin secretion in a glucose-dependent manner. The effect would be further augmented in the presence of a DPP-4 inhibitor, is what the question was. So they did this. I'm not going to go through the design, but effectively, no treatment for the same patients, randomized crossover, 20 milligrams of glycoside or sitagliptin normal dose, or the low dose SU. I don't know what the dose was that they used, but it would have been a much lower dose, plus a DPP-4. Actually, no, it was 20 milligrams of glycoside, 20 milligrams, so that is a low dose, and DP4, and the combination of the two. And they did a mixed meal tolerance test to look at glycemia. What did they find? Oh, it's quite obvious. So this is the control arm. Glucose goes up to about 13 and comes down. With SU, look, you get a big, decent effect, which is better than the DPP4. But the combination of the low dose SU gives you a very good benefit, so that the glucose postprandially goes up only to 10 instead of about 13. And here you can see the area under the curve. SU alone at low dose, DPP4, and the combination of SU plus DPP4. So you are getting a thing. Again, the key metric, and then they also looked at insulin sensitivity and glucose sensitivity. If you believe these things, I'm not fully convinced I do, but basically you're making more insulin, with a combination of SU and DPP4, as you would expect, both an incretin and a directed, a secretagogue effect of the SU. So low dose glycoside lowers blood glucose as more potently than sitagliptin, but an added effect in combination with the 2 glycoside sita. No increase in the rates of hypoglycemia. That's a really attractive feature, but it's a relatively small study. They only looked at it for a few weeks. Glucose reduction achieved with glycoside concentration far below those achieved with standard therapeutic doses, and lower dose and lower than of glucoside MR. May avoid the negative aspects of SU of high dose and the pharmacoeconomic benefit. So imagine again in South Asia, can you give people lower doses SU in combination with DPP4 to get a good glycemic benefit without causing hypo? Again, what you need to do is extend this concept to looking at changes in hemoglobin A1 over time. Is it meaningful changes, and what happens to weight and what happens to hypoglycemia? And you would need to do a trial compared to conventional SU, conventional DP4 in a longer term study. But I suspect that's where they're going. I'm not going to do this. I don't think that's that interesting or that. And my final study I wanted to talk about was back to the newer drugs, if I may. So there was a debate with Silvio Inzucci, who's a brilliant diabetologist in New York, in Yale. I think that's New York. Yeah. And then Francesco Giorgiorni, and they both made, so Silvio said, after the preferred second line therapy with type 2 is an SGLT2. So Francesco said it's GLP-1. Silvio's case was, well, look at all the brilliant evidence from all the trials in terms of not just MACE, but also CVD death, heart failure, and CKD progression. He also said, look, if you look at the best drugs that have benefit across hard kidney outcomes and albuminuria, it's the SGLT2s, not the GLP-1s. And then he also said, look, they also have benefits on blood pressure, weight, low hypoglycemia, and cardiorenal, and that this oral administration, they're more cost effective, no GI side effects, and usually no dose titration. Therefore, they should be preferred second line. Our colleague from Italy, I think it's Italy, from Bari, Italy, Professor Giorgini. Well, he said, look at the GLP-1. Now, he showed some real-world evidence, which I think is a bit dodgy, but never mind, showing that the benefits of SGLT2 and GLP-1, you can't really call them benefits in real-world data, but they were broadly similar. And that also with GLP-1, you got also benefits on MI, MACE, and heart failure and hospitalization for CVD. But of course, this is not trial data, so this is a bit dodgy. Having said that, the best trial evidence of GLP-1 was published by from my group. We just published it in the Lancet Diabetes, looking at the randomized trials. And GLP-1s do lower heart failure and kidney disease, but by much more modest extent, somewhere between 12 to 20%, instead of with SGLT2, they lower heart failure by about 30 to 40%. The one benefit of GLP-1 over SGLT2 is benefits in terms of stroke. GLP-1 reduced stroke by about 19 to 20%, whereas SGLT2 do not have benefit on stroke. And they may also have, GLP-1 may also have better benefits in PAD. So that would be my thoughts. Anyway, Professor Giorgini said, large reductions in hemoglobin A1 in addition to body weight. So yeah, they certainly do have better body weight benefits than SGLT2. Anti-atherosclerotic benefits, particularly stroke, I think is better with the GLP-1. Forget real world evidence. I wouldn't touch it with a barge pole. Look at the trial evidence. Most common side effects are GI, but they can be improved with slow dosing and going slow. And he's also said treatment could be continued with suspected or confirmed COVID infection, which is true. And but we're looking at trial evidence for SGLT2 as well. So we can have that debate here. And I'm going to leave that. I think that's all I wanted to say. I think if I can stop sharing, or we can keep on the trials if you want me to prefer. I think that's 40 minutes up. Yeah.
Thank you, Dr. Navi Sattar. You have reviewed 8 papers. And for your information, CVO Izuki was with us. Izuki was with us a few days back, reviewing his own 7 to 8 papers, what he thought best of EASD. So we had an interaction.
Oh, you had Silvio, did you? Yeah.
Yeah,
I mean,
we had it. And he spoke very well, chose very good articles.
Yeah,
very really. Now, it will be unfair if I don't answer the questions. I'll pose 3 questions which are there from the audience. Then I'll give it to my co-chairperson, Dr. Sanjay Kalra, as well as Dr. Uday Padke, their opinion and their questions, their reviews and clinical translation to that. First question is from Dr. Santosh Kumar Patna. Your comment on the difference in A1C with concomitant and sequential GLP-1 receptor unlock and SGLT2 versus duration 8, hour 10 and Gonzalez data. So what is your comment on this difference in HbA1c when used concomitantly sequential GLP-1 and SGLT2?
Well, I'd be interested to know what I don't quite know what the question is. We presented the data I presented was sustained 10, wasn't it?
Yeah.
So I'd be interested to know what the difference is. I mean, the data that I showed or that have been presented at the EASD, I think are pretty clear cut. And I mean, I wouldn't complicate it beyond this. We all of us know that you get weight loss with both drugs, but the mechanisms of action are different. One is an incretin effect, cutting caloric intake. The other is getting rid of sugar in your urine because of hypoglycemia. So clearly, if you add a GLP-1 on top of an SGLT2, you are going to get weight benefit. You are also going to get glycemic benefit, and you will get blood pressure benefit because the mechanisms of action of these 2 drugs, class of drugs, are completely different. So it makes complete sense. The other thing I would say is that the reason I think SGLT2 have cardiorenal benefits is that they're doing something hemodynamically by changing fluid in the interstitial volume or by reducing nephron stress or stress at the heart, which is not what GLP-1. I think the way GLP-1 is working predominantly is anti-atherosclerotic, with the GLP-1 effect on vasculature. But because they lose a bit of weight and they reduce blood pressure, they are also having ancillary benefits on heart failure risk, as well as the anti-atherosclerosis. And if you look at our meta-analysis that we published in Lancet Diabetes, the two studies which had the greatest heart failure benefit with GLP-1 were Amplitude O, and I think the other study was with albuglutide harmony. And those are the two studies where they had the best benefits on MI as well. So GLP-1 is reducing heart failure, reducing atherosclerosis and HFrEF. And I think it's atherosclerotic predominantly, with maybe a bit benefit of weight. SGLT2 is reducing heart failure and kidney through hemodynamic, and maybe other effects that Milton Packard tells you, cellular benefits in terms of starvation. I don't know, So and I think they're complementary. And I think all the evidence from trials that you see on risk factors, Amplitude O on outcomes, and also real world data suggest that these two drugs will have additive benefits on top of each other. That's what I would say. That would be my summary.
Yeah, but he has also asked about duration 8 trail and hour 10. How does it compare? Are you aware of it?
I don't know those data. I would be interested. What do those data show? I guess they're just showing risk factors, and I bet you they're showing the same thing, broadly speaking.
Yeah, I am also not, unless my colleague Dr. Sanjay Kalra and Dr. Uday, do you have any idea? I have no idea about it.
No.
That's right.
But sir, I think what Dr. Santosh is asking is, in Dr. Naveed's OPD, when you initiate a GLP-1 RA in a GLP-1 RA naive patient,
right, okay,
and when you initiate SGLT2 inhibitor in an SGLT2 naive patient, there will be some amount of side effects. You have to do a little bit of counseling. Is it worth the risk? A patient comes to you for the first time today, and now how long will it take you to explain to the patient? The patient has to handle diuresis as well as nausea, vomiting. Is it worth it, or would it be fine just waiting for a few days to start?
I think that's a very good point. I haven't thanks, Sanjay. I hadn't considered very often. I mean, I have not ever started them both at the same time. I've usually started them sequentially for the exact same reasons you said. I'm sure there are colleagues who've started them probably, but you're right. They probably started them within a few days or a couple of weeks after each other. Start the SGLT2 in bed, and then start the GLP-1, start low, go slow, and go up on various things. I think I'd be interested in your experience as well.
No, the question again is, I will never start SGLT2 inhibitors if the blood sugar is 250 and above. Okay, I wait till the blood sugar comes below 200 because symptoms may worsen also. So that's why when the HbA1c is 9, 10, 11, the best thing is to still start metformin, gliptins. My third choice will be SGLT2 when the A1C comes down, or this hyperglycemia comes down, because obviously But a GLP-1 you can start even ahead of it.
That's a fair point as well.
That's how I see. And of course, both of them are useful in obese patients. So my choice is not SGLT2 first, but it is always metformin first, then go to the gliptin, then third choice is SGLT2. And of course, cost of it is very high in India. Less than 0.1% of diabetics can afford, because 85% have to pay from their pocket. There's one more question all three of you can answer. Dr. Santosh Kumar Patna has asked, contribution of sarcopenia in the difference among Asians and West.
Do you want me to start, or do you? I can tell you what our data.
You can tell your opinion, then I'll ask Sanjay and Uday.
Yeah, no, I wouldn't call it sarcopenia. We are made as we are. I think what the evidence shows in the data that we've published, and we did a review of this. South Asians in the UK, certainly, first generation, they have about 10% less muscle mass and about 10% more fat mass. So we do have smaller engines and we carry more fuel, is the way I think about it, and that also explains that we have a lower cardiorespiratory fitness because we have less muscle mass, we have smaller engines. I think one of the, and the way to compensate for that would be that South Asians do need to stay leaner if we can, but we also, if we can, need to keep up our activity to maintain our muscle mass. Because if we start with less muscle and we have become more active, we're going to lose. We were already starting with less muscle. We're going to lose it quickly and become sarcopenic quicker. So absolutely, I think, the good news though is that we've got a paper coming out in diabetologia. Second and third generation South Asians in the UK using UK Biobank look a bit taller. They have a smaller waist-hip ratio, and they have a lower risk of diabetes by about 20% than the first generation. So things are changing.
Dr. Uday, what's your take on this contribution of sarcopenia among Asians as well as West?
I completely agree with what Dr. Naveed said. And somehow Indians, for the muscle building to occur also, two things probably might be required. One, of course, is protein intake, which is not so good in Indians. And second is the propensity to do some resistance training or strength training, which most people do not have access to in India. So they may walk or they may do a fair bit of aerobic activity for those who exercise, but resistance training is lacking. So yes, as compared to our counterparts in the UK or US, certainly I think we have a lesser muscle mass with more body fat. And that's also from so many other evidences like Yasnik's study and Yudkin's contribution about the thin fat Indians right from birth. So I think, yes, to that extent, we are sarcopenic right from birth.
Yeah, another thing is the Yagnik, the so-called thin fat Indian is not an entity. It is compared to the Westerners. It is not that you have an entity that all thin Indians have more fat. Actually, it is only one case where he is Kapnik fatted. We should not mistake all Indians are thin, all Indians have fat is also not right. Because Yagnik was very clear when we had a meeting last time. People always quote by one case as something like a phenotype and all. No, it is not true. When I'm compared to another European, this is what one case that is true. Yeah, it is not that all Indians. Other thing is, Dr. Sanjay, this frailty, what we are talking, the sarcopenia. As Indian becomes older, let us take for SGLT2. Now the classification is mild, moderate, and severe sarcopenia. How SGLT2 should not be used in moderate and mild, whereas the mild one can be used. So what do you see use of these SGLT2 inhibitors in a patient with sarcopenia, elderly patient, compared to normal?
This is a very important topic, sir. And for everybody who is listening, let us just revise the definition of sarcopenia. The classic definition of sarcopenia is you suspect it if there is reduced muscle mass, if there is reduced muscle strength or reduced muscle function. You confirm it if there is reduced muscle mass. This is classic. This comes from the West and it also comes from Eastern Asia. But now a South Asian consensus has been developed, which is a 12-country consensus under publication, where we say you define sarcopenia the same way you define metabolic syndrome or the way you define polycystic ovary syndrome. We take 2 out of 3. These 2 out of 3 will be any 2 out of reduced muscle mass, muscle strength, or muscle function. So we should be aware of the definition. Secondly, we should be aware that sarcopenia can be primary and secondary. Primary means with aging, everybody will become relatively sarcopenic. Secondary means in a person with obesity or with uncontrolled diabetes, there can be sarcopenia. With this background, when we talk of using SGLT2 inhibitors or even GLP-1RA in elderly persons, we should not define elderly just by the calendar or chronological age. We should go according to a frail index or a frailty index. And here, if you have somebody who is already debilitated, somebody who has poor muscle strength, muscle mass, and is not the best candidate, you know that he or she has never done resistance exercises in the past 70 years and is not going to begin now. Then maybe SGLT2 inhibitors would not be a good drug of choice. We would want to give more of anabolic drugs. Both GLP-1RA and SGLT2 inhibitors are not anabolic. It is insulin, which is an anabolic drug. And if you want a substitute, an oral one, you might as well choose a sulfonylurea. And Dr. Naveed has spoken about even glycoside 20 milligram being able to help sitagliptin. So just look at the frailty of your patient. What the model that we use here, Dr. Naveed, is something called a metabolic triage. You divide all patients into 3: maladaptive anabolic, eubolic, and catabolic. Now, when we read the guidelines from US, they just keep on harping about weight loss, weight loss, weight loss. When ACE talks about its philosophy, out of 14 points, 8 are related to weight loss.
Okay.
In India, that's not correct. It should be more a weight optimization. 1/3 of my patients are malnourished also. They may not be malnourished in the bigger cities, but if you go to the smaller towns and districts, you will have lean, malnourished patients. All of them will not be LADA or pancreatic diabetes. Most of them will actually be very poorly controlled type 2 diabetes. Here we need to increase the weight. And again, GLP-1RA and SGLT2 inhibitors will not be good drugs. GLP-1RA is a calorie restrictor and a calorie restriction mimetic. SGLT2 inhibitor is a calorie restriction mimetic. If your person is already calorie restricted, either the intake is too little, patient is on a keto diet, or the absorption is limited for whatever reason, then it would be a punishment giving SGLT2 inhibitor to such a patient. And that is when all these therapeutic mishaps and misadventures come into play, because we are choosing the wrong patient. So as an Indian physician, just see if your patient is eubolic or maladaptively anabolic, then these are the drugs of choice. If not, then there are other drugs to choose from.
Good.
Yeah,
Dr.
okay.
Sanjay, you told the definition, clinical importance, everything. Now they will ask, how do you measure sarcopenia or frailty? So he is a clinician at bedside. He does not have all that. How do you say this patient has sarcopenia, frailty? On what basis you are going to quantitatively measure? And if you are going to follow up these patients with drugs which are anabolic, not catabolic, how do you say my patient is?
Simple ways of doing that. The simplest way to check muscle strength would be using a hand dynamometer. Even if you don't have a hand dynamometer, you just shake hands with your patient. If your patient is able to shake hands with you properly, based upon age and gender, then your patient is fine, good to go. If your patient can get up from a chair and walk, and these are all objective validated tests, but if your patient can get up without support from a chair, and she can walk a distance of maybe 6 feet, that's fine. If you want to check muscle mass, do a mid-arm circumference and a mid-calf circumference. The mid-calf circumference should be more than 33 centimeters in an Indian. And that should suffice.
Good. These are all simple clinical measurements to say whether he has sarcopenia or not. You have defined it. Also say how to measure. Even bedside, you don't need an extraordinary equipment. Thank you very much. There's a question here. On the heels of EASD, that is European Society of Cardiology, I think, any suggestion of using GLP-1 on top of SGLT2 in obese patients with heart failure with preserved ejection fraction? Any thoughts, diabetic, non-diabetic? Because HFpEF, that is heart failure with preserved ejection fraction, is increasing. To Dr. Naveed Sattar.
Well, I mean, we don't really have any trials in that space. So it's a good question. And actually, it's a question that needs a trial. And I'll be honest, we have designed a trial just to answer that specific question, not just even HFpEF, but even also in HFrEF. There are two small-scale studies of GLP-1 in heart failure, which didn't show any benefit or necessarily, some people were concerned about one of them, but they're too small. We need an outcome trial. And what people have been more encouraged about is the more recent GLP-1 data, like Amplitudo. And based on those results, I can tell you some heart failure specialists have come to me and said, could we do a GLP-1 epaglenitide trial in our patients with HFrEF or PEF who are already on an SGLT2, and would there be any benefit of adding a GLP-1? And the only way you're going to know that is by doing a proper outcome trial. We don't have them yet. So my answer would be, I don't know, but we need to trial that particular question.
Dr. Uday, you have any experience in using the patients with
No,
both SGLT2? Yeah.
I confess I cannot say in an anecdotal manner what I think. So the whole concept of this HEF preserved ejection fraction has come up new, and we have started to just look at these echoes of late and trying to figure out from our cardiologist friends what exactly is meant by all that, because even in the category of heart failure with preserved ejection fraction, the echocardiology reports that we get keep on saying there is some diastolic dysfunction. If you send the report to a cardiologist friend, he says, no, I think it's normal. Everyone keeps writing type 1 or grade 1 diastolic dysfunction. So I'm not sure still how exactly, as endocrinologists, we are supposed to diagnose diastolic dysfunction unless we earn some mastery in reading echo reports, which I confess I do not have right now. So there are so many factors to look at, and I am not sure I'm competent enough right now to diagnose HFpEF very accurately.
No, the question is today, I had a patient. He's my relative, friend's relative. He's 51-year-old, diabetic 24 years, and hypertensive 24 years. I had seen him at the age of 18. Now, last week, he developed heart failure, typical left ventricular failure, and he has got nocturnal Parkinson dyspnea. Now he weighs 90 kg, 10 kgs more, he's 182. Ejection fraction done 3 times in 1 week, 33%, 30%. Today he got MRI, which shows 29. So this is a definite reduced ejection fraction. When patients have ejection fraction 40 to 60, okay, that is probably preserved. Less than 40 is low, and more than 60 is normal ejection fraction. That is preserved ejection fraction. So patients can have heart failure with normal, low, or very low this one. This is how the cardiologists. We are not cardiologists. But when you ask for an echo, forget about diastolic dysfunction. I know it is more of probably the technician who is doing it. Some are echo technician, maybe cardiac. But these are the ones when you get an ejection fraction 30, 40, and above 60, you know it is well preserved, or low or very low like that, reduced ejection fraction and all that. So in those patients, initially, most of them are on diuretics. Now the question is, next choice is definitely SGLT2 inhibitor. And you don't prefer, even in a preserved one, you don't prefer, though the cardiovascular benefit, as Dr. Navid said, my choice is always SGLT2 inhibitor.
Yes,
now,
agree.
Even non-diabetics don't come to you and me, they go to cardiologists. Cardiologists use it. And as the data has shown, whether diabetic, non-diabetic, the benefit is there. Apart from this, Dr. Sanjay, what is your experience of using SGLT2 inhibitors as well as the GLP-1 analog in type 2 diabetics, where all of them obese, whether PCOD or non-PCOD?
I have used these drugs together in a few patients, but the driving factor has not been heart failure or heart health. It has been more of obesity or weight loss. Let us understand, like Dr. Uday Phadke sir said, that heart failure is evolving very rapidly. And when you look at the current staging, any patient who enters a metabolic clinic or an endocrine clinic by default already has stage A heart failure. Whether the patient is hyperpituitary or hypopituitary, hyperthyroid, hypothyroid, hypergonad, hypogonad, Addison's disease, Cushing's, either way, that risk factor is always there. So we have to be careful, we have to be watchful, we have to be vigilant. I do use, like I said, in a few patients, GLP-1R and SGLT2 inhibitor together. But the main aim there is weight loss. I do not think so much about the heart as a primary target. If I'm thinking about the heart as a primary target, I would always want to take the help of my cardiology colleague. And
that is true. We cannot treat heart failure, but the best result I see in PCOD. PCOD for diabetic obese, I have seen 18 to 20 kg weight loss. You withdraw GLP-1, 10 kg comes back. Withdraw SGLT2, 20 kg comes. Of all the diabetics, PCODs are the one which respond beautifully. And I have a lot of patients with this combination. Unfortunately, they cannot afford this. That is the cost. The cost is not a factor. Side effect is not a factor. Lot of our 65% of our patients are obese. Here's the questions to both of you.
One of the indications of liraglutide is actually an upcoming marriage. So
in fact, this is exactly what I said 4 years back.
Short-term indication. It works very well.
My daughter is 103 kg. See that she loses 20 kg, and another 6 months I will finish her marriage. After that, I am not bothered what happens to her. Yeah. This is typical Indian mentality, as you said. I think north or east, south or west, this is what we see. Here's the questions to both of you are not cardiologists. Presume you commonly measure NT-proBNP in suspected heart failure in your practice.
Well, I put that question up because, I don't know, it depends if you've got the assay available. Certainly, we've been asked that question, in which of our diabetes patients should we suspect heart failure, or should we actually more commonly measure NT-proBNP to look for heart failure? And that's the big question now. We can't measure it in everybody because it's too expensive. Certainly those people who have symptoms, orthopnea, or maybe those people on loop diuretics, and then those who have, lots of risk factors is probably the people we would measure it on. But we can't. What we need is guidance in whom we measure it. But I was asking whether it's measured commonly in India.
It is not, because I'm sure Uday as well as Sanjay, myself, have a lab with us wherever. We do all the tests. At least I don't have that NT-proBNP, because nowadays I can get a point of care. I'm trying to get it. As you said, if I can see every diabetic, okay, ECG we don't do echo and all. If we can do, the patient today I saw 1 week back, he got breathlessness. Next day his pro-NBT was 1,526. The normal in that. I mean, this is a frank case where you don't need it at all. It's only a quantification how it has improved. But Dr. Uday, do you use it regularly in your clinic, in the lab? No. Dr. Sanjay?
No.
It is symptom driven, actually.
Exactly.
And something that I use, and I would encourage all the listeners to follow, is something called the BREST questionnaire. BREST. It comes from France, a validated questionnaire where all you have to do is take a history, do a simple examination, and look at the ECG. And with that, there is a 97% chance that you will be able to diagnose heart failure correctly. And just a single clinical pearl for everybody, which I'm sure all the physicians know. If you have a patient who is coming in at 60, 65, 70 years with breathlessness, chances are minimal that it will be a pulmonary cause. It is not going to be tuberculosis. It is not going to be asthma or COPD. If it is a recent onset breathlessness at age 60 plus, it is most probably going to be cardiac or maybe COVID last year.
Other thing is weakness. Many times we say weakness. As you said, 60, 65, he's perfectly all right. Weakness is first, I would like to rule out cardiac. He will not be able to say breathlessness. Weakness. I was walking 5 kilometers, 3 kilometers, 2 kilometers. This is what it is. I think we have already exceeded our time. So it's already 10:05. I thank Dr. Naveed Sattar for excellent 8 presentation. I wish we had 1 more hour. I am sure both my co-chairpersons agree with me. Would have gone probably threadbare into each article, especially the one you said, where sitting for long. In say in osteoporosis, they say, if we can sit, don't lie down. If we can stand, don't sit. If we can walk, please stand, don't stand. If we can run, don't even walk out. Same thing holds good for cardiology. Nowadays, I see physicians, 6 feet difference. You start your clinic 9 o'clock. In India, till 3 o'clock, they don't even get up because I don't want to examine my patient. And there are people who work morning 9 o'clock to 11:30 in the night endocrinology, 40 patients in these groups. So a lot of doctors have said, okay, let me have my laptop here. I will stand. I will not sit 2 hours. Patient can sit. I can stand and do it. This is what software engineers are already doing. Next phases will have probably a slow moving, what you call walker, and you are standing on that and you are seeing the patient, listening to the entering or whatever prescription. That's all of us, because a lot of them don't have 10,000 steps. That will take maybe 2 hours. How many of us have 2 hours morning, 6 to 10, to take 10,000 steps? So I go to gym in the morning, walking in the evening, provided there are no patients.
Sir, I do my OPD standing, sir.
Good. That's
I don't sit at all. I don't have a chair anymore.
Yeah. You please have a treadmill also. Slowly it will go at maybe 1 kilometer per hour, so that in 2 hours you would have walked 2 kilometers. Patient will not realize Dr. Sanjay is not standing, he is walking on the treadmill also. That is next phase. I also do that because otherwise 4 hours you are sitting. Rather than, and maybe what the AD and others fix 150 minutes per week is not sufficient. If you want cardiovascular, maybe 5 hours. There are some studies which show maybe Indians, we should have 5 hours exercise per week. Exercise is not during work, it is leisure activity. Don't say, sir, I'm walking so much, I'm standing so much. No, if it's a leisure activity of 5 hours per week, that is better than like people say in shop floor, I walk around and all. I don't consider as an exercise at all. You keep that 5 hours in 7 days. I think that will be better for cardiovascular rather than diabetes. With this note, I thank Professor Naveed Sattar, Dr. Uday Patke, Dr. Sanjay Kalra for an excellent interaction. My only symbol is I wish I had another 30 to 40 minutes would have done justice to all the topics. Over to Dr. Altaf Qazi for his comments and final conclusion.
Thank you very much, sir, for moderating this session. I, on behalf of Acumentis and our division Noveltis, thank all esteemed faculties for participating in EASD Connect program. I express my individual gratitude to Dr. Prasanna Kumar, Dr. Uday Fatke, Dr. Sanjay Kalra, and Dr. Naveed Sattar. My gratitude goes to each and every delegate who has joined this finale of EASD Connect. I'm indeed glad to mention that, sir, we had about 1,100 doctors across the country today in India who have joined this program today at this hour. It is 10 p.m. in India. Who have joined this program. And my sincere thanks to my CEO, Mr. Pradeep Patni, and management team at Acumentis, and all my colleagues from both sales and marketing who have been, made this program possible today. So thank you once again, all doctors, and thank you, delegates. Thank you so much once again.
Thank you.
Good night.
Thank you so much.
Good night. Good night.
Good night. Sir.
Good night. Bye.
Right.
Recording stopped.
Yeah, Mr. Kazi.
Yeah. So good discussion.